Hello everybody, welcome to Medical Missions TV. Andy, thank you for joining us. We're here with Andy Mayo at Medical Benevolence Foundation, and I appreciate you having me come down to your office and visit with you a little bit.
It's great to have you drop by.
Yeah, well, I was hoping maybe you could share a little bit about what MBF is and what you guys do here.
Okay. Well, Greg, MBF has been around for 56 years. We've worked in over 32 countries and provided well over $150 million worth of supplies, equipment, services, teams, all nature of things to our partners in developing countries. We work with church-owned medical ministries. That's hospitals, nursing schools, clinics.
That's why I wanted to come and talk to you, because that's obviously my passion as well, and we've been talking about this stuff for a long time, and kind of some of the challenges that are happening for mission hospitals out there. We know that there's hundreds of them out there, and so many of them are fighting for survival.
Sure.
And you guys come alongside them and help them through that process and help them stay alive. Can you tell me what's changed over the years in mission hospitals from your perspective?
Well, and let me back up for a second. One of the things you just mentioned that makes MBF somewhat unique is that we don't own anything. So we don't own a hospital, we don't own clinics. We work with churches, indigenous churches in those countries that own the ministry. So we're partnering, we're equipping, we're enabling them to get there. But one of the things that we're seeing, it's becoming very urgent, is that medical care, the medical industry in developing countries is at a tipping point, or has already reached a tipping point and is changing rapidly. If you just think in concept of the changes that the United States went through from, say, the early 1960s up to 2000. In the early 60s, 28% of nurses had their bachelor's degree. Today, somewhere close to 88% of nurses working in hospitals have their bachelor's degree. Everything from technology to computers, clinical pathways, all of those things in the United States changed significantly in terms of the business of healthcare. Well, that is exactly what's going to happen in developing countries over the next 10 years. And the challenges, mission hospitals aren't anywhere close to being prepared. I heard a presentation one time, they said, once we had mission because we existed. Well, no longer do we have mission because there are government hospitals, there are NGOs, there are for-profit hospitals, for-profit clinics that are all coming into the market, and mission hospitals are more and more being marginalized and pushed aside if they can't compete.
So how do we keep them alive? How do we help them alongside them and serve and support what they're doing?
Well, having been around the American hospital industry for a few years, I laugh and I say, I'm not sure if we're as smart as we think we are, and I got to be careful that we think we have all the solutions when I look at the American market and say, oh my gosh, I don't know that I'd inflict that upon anybody. I think some of the critical things we need to think about, and I think anybody would say, if you looked at a mission hospital, what are some of the most important things that they all struggle with? Governance, leadership, healthcare leadership, the sophistication of running a modern hospital when it comes to finances and HR and all of those kinds of things. Those things are coming, and you don't have MHAs or MPAs sitting in the seats of those hospitals. Just even the clinical skills and protocols and standards. Not to mention the equipment. In those countries, it's going to be an arms race for equipment, just like it's been in the United States. And MRIs, CTs, digital X-rays, robotic equipment, all of those things are capital intensive for a mission hospital. And the one thing mission hospitals don't have is capital.
Yes.
So, that's sort of like the definition of a mission hospital is you don't have any capital.
Man, you raised some good points there about administrative functionality, that is a big aspect. We spend healthcare professionals to work in these facilities, but there's still a great need for administrative sides of that, and just trying to figure out how to provide functional healthcare services in a context where the payer base makes $2 a day or less.
Right.
How do you do that? And can you speak to that administrative need? I mean, you were administrator of a
Sure.
mission hospital for a
Well,
while.
and I think that medical mission organizations can take a look and say, okay, for 100 years, we've been sending doctors and nurses, because that's what the need was. We haven't been sending any administrators. And we sort of scratch our head and say, gee, I don't understand what the problem is. Well, we sort of have to understand the business side of this. I think the challenge will be helping our partners begin to think about their ministry from a business perspective. Now, you have to take a step back and say, okay, these are medical ministries, so by definition, they're in most cases managed or run by the church, who itself, doesn't have a lot of professional business, CFOs, and so the critical component for us is thinking through how do we get them to begin thinking about how these things work together. I had a personal conversation with the general secretary of a synod in a country in East Africa, and I said, "What's your vision of the future? For the hospitals and medical ministry?" And his response to me is, "Well, we're just going to care for the poor." Well, as a businessman, I'm looking at that thinking, well, you got to have a mix of paying and non-paying patients, because your source of donations is not going to be there forever.
Yeah.
But
And
he didn't have that perspective.
And that's a tough one to gain. I've seen that manifest in India in a few places where it works really well, where there's some level of care for every patient, and there are some accommodations even that are there to accommodate paying patients versus So I think there is a time to think outside of the box. Can you think of any examples where that's being done well?
Well, if to your example, I have experience with some hospitals, Christian hospitals in India, and for whatever, for a variety of reasons, I think they have been forced into the survival mode, so they have adapted and grown and sort of followed the path of the not-for-profit hospitals in the United States and said, we got to figure out a way, and I think in India, the source of donations dried up sooner, so they were forced into that survival mode. And then I think in India, you have a growing culture of capitalism, which, helped with that as well. So there's a number of instances of not-for-profit Christian hospitals in India that are surviving very well. We see, some of our partner hospitals, Kikuyu Hospital, just outside of Nairobi, is a great example, that if we didn't exist, tomorrow they would say, gee, we miss you guys, but they would continue on and continue to survive. So they're an example of, they have a very big orthopedic program, a very big ophthalmology program, and so they're serving both paying and non-paying patients.
Sure.
The interesting challenge with them is we have to have a conversation with them of maintaining their charity care.
Yeah.
This pendulum is almost swung to the point where they are not focused on poor patients anymore. So it's an interesting dynamic.
What other big challenges do you see in the medical mission world right now? What are the things that that you call out as saying this is really going to be an ongoing challenge in the coming years?
Well, I'd change it to a major opportunity. I think that we're seeing, and specifically related to sub-Saharan Africa, we're seeing a movement towards specialty training for physicians and subspecialty training. And I think that, for example, in Malawi, there are 30 physicians, 30 surgeons for the entire country. So that's like 30 surgeons for the whole city of Los Angeles. Now, they understand and have recognized, and I've had conversations with some of the professors at their main college of medicine, that their system is going to have to go more towards a residency training program, much like the United States, in order to solve that capacity, that capabilities. I think there's a tremendous opportunity for mission hospitals to be at the forefront of both surgical residency training as well as internal medicine residency training and the subspecialties. I think that opportunity is right there coming, and to the extent that the mission hospitals grab that quest for quality, they'll continue to be the leaders.
So let me ask you, one of the things that I really love about MBF is your heart for nursing and developing nursing, quality nurses in some of the countries that we work in. As a nurse, I kind of appreciate
I thought maybe
that.
that's where it came from.
But no, I think you guys, I think your focus is in the right place, because it doesn't matter what, we could provide the best medical care and physicians and specialty physicians in a hospital.
Right.
But if the nursing care isn't there, we all know that the quality of care that hospitals can provide is still awful. So you guys have taken on both arms of that and have a Center for Nursing Leadership. Is that what?
Yeah, the Mary Kay Center for Global Nursing Development. I wish that I could sit here and tell you that we were so smart that we came up with this strategy years ago and we're living it out. The truth is that for many years, MBF has been connected with the nursing schools because in most instances, mission hospitals started an associated mission or nursing school to solve their own problem. They needed nurses, and so they started a nursing school, and those little nursing schools are now sort of been cast out on their own, and they're surviving. Well, so MBF for many years has, through our donors, provided nursing scholarships through many schools. And in the case of Haiti, we were instrumental in building the first baccalaureate nursing program, FSIL, in Haiti. It was attached to the hospital. We were able to get some grants. There was a group that pulled together. We were able to get the grants to build the building, and then there was a group that pulled together the curriculum. And today, that program in Haiti it's the best nursing school in Haiti. They've just started a master's program, and next year we'll graduate the first class of master's prepared nurses in Haiti.
Oh, that's
very exciting.
That is really exciting.
Well, 3 years ago, we received a gift from a donor a very generous gift that enabled us to sort of consolidate what we were doing we called it the Mary Kay Center, so that we could specifically take up nursing and nursing schools, nursing education as a focus. Wonderful, one of those unique opportunities that a donor interest and our interest came together at the same time, and they were very generous with us. So we're in the process of trying to build those bridges, build those relationships with hospital partners, with nursing schools, to begin to identify what are the educational needs, how can we assist in that, and how can we really impact the quality of nursing in mission hospitals through the educational side and building the capabilities of nurses. I'm like you, I've been a hospital administrator for a long time, and I would say one of the biggest the big changes in healthcare in the United States were driven by nursing. That focus on quality has really driven the hospital care in the United States. And so, to that end, I believe the drivers of quality medical care in mission hospitals are going to be their nursing staff. And to the extent that we can help, we can support, we can get resources for that, we want to do it. Here in 2 weeks, we have a wonderful opportunity. The Director of Nursing Services, Dr. Mandili from Kenya, is coming to the United States at our invitation, and she's going to spend a week here touring a number of hospitals and nursing schools here in Houston. She's going to visit Texas A&M and finishing up in Washington, D.C. With the express purpose of being here is to sort of do a survey of what are the latest trends and the things going on in American nursing schools and hospitals, to inform her when she goes back to Kenya to think about, okay, what needs to be on the agenda for the government of Kenya for the next 10 years in Kenya. So that's a perfect way for us to be an influence and to be a partner and come alongside and hopefully change and impact Kenya for years to come.
So you guys are doing a pre-conference workshop at the upcoming Mobilizing Medical Missions Conference here in Houston. So tell me a little bit about what you have in store for the participants that are coming in your direction for that.
Well, it's a great partnership between our two organizations. You all are doing the morning and we're doing the afternoon. And to me, that worked out perfectly. It's a sort of a nice tie-in. The afternoon is going to be focused on nurses, and our goal there really is to equip nurses who might be interested in some type of short-term or long-term medical missions opportunity of some kind, to give them a realistic snapshot of what to expect. So the first part of it, we have the Dr. Mandili from Kenya, we have a nurse from Haiti, and a nurse from Latin America, who are going to literally just give us a visual tour of what to expect in a mission hospital if we were to get on a plane and go to a country and land, so that someone who's never been to a country before has a realistic expectation of, oh, I didn't know they did that there, or I need to be prepared, or something of that nature. So that's the first session. The second part of the session will be then the panel of the three of them talking about the greatest needs. So again, if I'm a nurse and I'm interested in a medical missions trip, what kinds of things do I need to be thinking about that I could do, or how could I plug in, or what are their needs?
Yeah.
Again, Haiti, Kenya, Guatemala, Honduras.
Yeah.
So we have all sort of three different types. And then the last part of the session, the last third, is going to be roundtables, where it's sort of a combination of networking and opportunity to ask direct questions. So the speakers, plus we have some other folks that will be there. So if you're interested in Kenya, you can go sit at the Kenya table and ask some specific questions. And it'll be a little bit like speed dating, because we will rotate people among tables. But what we found last year when we had a luncheon with the nurses is there was a desire among those attending to just have some community and get to know each other. So you say, here's 50 nurses that all showed up at the conference. They don't even know who each other is. And then they all have somewhat of the same desire of, I'd like to do something. And they enjoyed getting together in smaller groups, hearing from each other and hearing what the other one was planning to do. So it stimulated them. And got them. A lot of times we as individuals, we think we would like to go do something, but we're sort of stuck there feeling a little bit lonely. And if you can go sit at a table with 10 other professionals who are just like you and have a conversation, get you encouraged and spurred, and you say, no, this is a reasonable thing I could do, and hopefully that will result in action. They'll actually get involved, and they'll call you up and volunteer to become a lifelong missionary. So our goal is to make your phone ring.
Okay, well, I like that goal. I do like the idea of, connecting nurses with mission hospital and health program opportunities versus just the traditional kind of mission model where we're going to take a bunch of North American healthcare folks from a church here and set up in a church or in a school and give out medicines. I struggle with that one a little bit, and I love the opportunity to have, to connect the two worlds, that short-term mission world with a passion to all of these hospitals and health programs out there that really need this support, but they don't know each other exists. So,
well,
I really like that.
One of our goals would be, hopefully every nurse will walk away with 5 practical things that are needs that he or she could go home and be prepared to teach. And so that when they're volunteering for a trip, and there's some communications with the partner where they're going, they can say, hey, I've got 5 things here. Are any of those of value to you? I guarantee you 4 out of the 5 will be on the list of their partner. And they'll say, oh, can you do a session on, wound care for burn victims? That was one I just saw from Haiti just a few minutes ago. Well, how would anybody have known that was on the continuing ed list if somebody hadn't told them? Sure. And every single one of our partners out there have burn victims all the time, from fires or whatever it is, and the nursing staff would love a session on how do you care for wounds. Now, not every nurse is that's going to be on the top 10 things she wants to do, but it's an example of, if I only knew that, I could prepare that and go being prepared to teach them.
That's awesome. Well, Andy, thank you for taking time out today. I appreciate it. We love you guys at MDF and what you do.
We're thankful for what you do, and we couldn't be a greater supporter. And I want to see you have thousands of folks out there engaged and working in the field.
Well, I'm not sure about the thousands idea, but I am sure about making sure we care for those that we have out there really well already. So,
Great.
all right.
Thanks, man.
Thanks.